to convert a breech presentation to a cephalic presentation. So, what are the very important things in ECV? When it should be done, why it should be done, what are the prerequisites for ECV? Prerequisites of ECV. What are the principles of ECV? What are the contraindications of ECV? What are the complications of ECV? What is success rate? What is failure rate? And what are the alternatives? So under these headings, we have to discuss. I think I'm going very slowly today, no? It is in the 10:50 and I have so much to cover. Okay. So if I'm very fast from now, you please stop me. But yeah, so when it should be done, the ideal time for doing an external cephalic version, it is external. So you're doing over the maternal abdomen. So how do we do? So it is basically maneuvering over the maternal abdomen. You are not putting your hand inside the uterus and doing. So doing an internal procedure is different. This is doing from outside. That's why it is called as an external cephalic version because you're getting the head below. It is called a cephalic version. So you're converting basically a breech presentation into a cephalic presentation and it is done over the maternal abdomen on an external basis and not an internal basis. And there's something called as IPV, which is internal podalic version. So what is internal podalic version? You're putting your hand inside the uterus and manipulating the baby. And the only indication of IPV in modern obstetrics is delivering the second
Second
twin
one
in
in
cases of a
transverse.
transverse lie. Okay, so if it's a transverse lie, second twin, you shift the mother to the OT, give IV sedation, and put your hand inside, grab the limbs, and do an IPV followed by a breech extraction. So that is the only indication where you're doing an internal codalic version. And what is an indication for external cephalic version? Obviously, when there is a breech presentation and when you have to do. So ideally, it should be done between 36 to 37 weeks of gestation. So why between 36 to 37 weeks of gestation? If you do very earlier, like 32, 34, ma'am, it's easy to do in 32 because baby is small, liquor is more. It is easy to do. But what will happen? The
It may be
spontaneous
come.
reversion will happen. So obviously, if you do again after next week, again it would a baby itself would have done one pulti and it would have come back to breech presentation that you don't want to do. So that's why the spontaneous reversion rate will not be more if you do between 36 to 37 weeks. So that is the first why to answer why between 36 to 37. The second thing is though if she goes into labor or if she goes into abruption or if she goes into fetal distress while doing the procedure, it might you might take her for a cesarean section, but it will not compromise over the maturity of the baby. So ECV might be to I don't know. Except Supriya, I think everyone can understand Kannada. ECV might be to you don't want to give a preterm baby to the mother because preterm babies are associated with more complications, both morbidity and mortality. So that's why I will do ECV and you do ECV. The way mother goes into abruption, you take for an emergency cesarean at 32 weeks, you give 1 kg baby to the mother. It is not good on our part. So that is why the chances of preterm labor and the other complications might be more if you do it and if it results in a delivery. So you do not want to give a preterm birth or preterm baby to the mother. So that is why it is ideal to do between 36 to 37. Ma'am, then I will not do between 36 to 37. I will do at 40. No, you cannot do at 40 because as the gestational age increases, the liquor decreases and it is very difficult to do an external cephalic version when there is decreased liquor. That is when there is oligohydramnios and the baby and it will be like the uterus will be hugging the fetus. You cannot manipulate from outside. That's why the ideal gestational age to do an external cephalic version is between 36 to 37 weeks of gestation. Next, what are the prerequisites? Obviously, singleton pregnancy, And why are you doing an ECV? To facilitate a vaginal delivery. You want to convert it into cephalic presentation and allow the mother to go for a vaginal delivery. So you have to have some prerequisites. For a vaginal delivery, what all prerequisites you require, the same applies for an external cephalic version also. So there should be, the pelvis should be adequate. It should be a singleton pregnancy. You have to rule out placenta previa and other cord abnormalities. There should not be oligohydramnios or polyhydramnios. The baby should be average size, that is between 2.5 to 3.5 kg. So all these are the prerequisites for doing an external cephalic version. So version, and the membrane should be intact and the mother should not be in labor. The uterus should be relaxed. Okay. So again, I will repeat: singleton, adequate pelvis, adequate liquor, average size baby between 2.5 to 3.5 kg. There should be no placenta previa and other contraindications of vaginal delivery. And there should, what else did I tell?
Rule out oligo
Adequate
and
liquor.
Poly.
Membrane should be intact.
Membrane should be, yeah, that is a very important thing. In PPROM, you can't, or PROM, you cannot tell I will do external cephalic version now. So membrane should be intact and the mother should not be in labor.
Labor.
So these are the very important prerequisites for doing an external cephalic version. So what is the principles of ECV? Principles of ECV, there are two important principles. This I think it's not given in any books. I think one of my teacher told, flexion of the head should be maintained. So for example, this baby you see here, the baby is like this. You cannot turn the baby like this because the head will be extended. So you're not, they have shown in this picture is absolutely wrong. I don't know why I did not realize, but now I am seeing. So this, they have told backward roll and they have shown the baby's head to be in this side. And you cannot roll the baby like this because the head gets extended. You cannot extend the head and deliver. Okay. So one is to maintain the flexion of the baby. So in this, they've shown it properly. So this is the baby's head. The flexion should be maintained. You should not do extension. Okay. The second important principle is shortest route should be followed. For example, the head is, where is my point here? The head is here. You cannot take the baby till here. Okay, this is the shortest route. From here, it is easy to hear. For our example, transverse lie, head is here. Just get it here. If the head is here, just get it here. So both of this should be applicable. So both flexion and the shortest route. Understood? Any doubt in this? The flexion of the fetal head should be maintained and the shortest route to do an external cephalic version you have to do. And what are the contraindications? Obviously, what all are the contraindications? Contracted pelvis, placenta previa, multiple gestation, oligohydramnios, polyhydramnios, low birth weight baby, large for gestational age baby, all these PPROM, PROM, mother in labor, abruption, all these are contraindications for ECV. Complications, fetal distress, PROM, onset of labor, abruption, cord compression, cord prolapse. All these are complications. So what are complications? Abruption can occur because of too much of manipulation. There might be premature separation of the placenta. There might be membranes rupture. The baby may go into cord compression and fetal distress. Sometimes there might be rupture of membranes and cord prolapse. And there might be changes in the CTG. So if the changes of the CTG or decelerations are lasting for 3 minutes or less than 3 minutes, if the decelerations are less than 3 minutes or if the bradycardia is less than 3 minutes during the procedure, it is absolutely fine. Because when you are manipulating the fetus from above, there might be slight decelerations or bradycardia. But if the decelerations or bradycardia is more than 3 minutes up to 6 minutes, then if it is going for 6 minutes, definitely take her up for cesarean section. It is C actually, cesarean section. Okay, for 3 minutes tanka, it is okay. So if it is going beyond and it is lasting for prolonged bradycardia for up to 6 minutes, shift to OT and do a cesarean section. Next, coming to the procedure as such. So I will repeat, I will tell you, please remember, it's a labor room procedure. It is not done in the OPD, not done in the OT. It's a labor room procedure. It does not require any anesthesia. You can just give a tocolytic. And the tocolytic which is preferred is terbutaline 250 microgram subcutaneous stat dose. Ask the mother to empty the bladder and do an NST for 20 minutes. Put her in dorsal position. Under ultrasound guidance, confirm the presentation to be breech presentation. And with ultrasound, and they have told apply like slight lubricative jelly to the abdomen so that it is easy for manipulation. That is the clinician's discretion. Under ultrasound guidance, grasp the podalic pole with one hand and the cephalic pole with other hand and decide which side you want to rotate based on the principles which I told you. Flexion should be maintained and the shortest route to be covered. And there are two methods of external cephalic version. One is the forward roll technique and a backward flip technique. Forward roll is also called as somersault method. So you know the somersault. Backward flip is a reverse somersault method. So forward roll, backward flip. So you're holding the podalic pole and you're slightly turning. And once you reach the transverse position, shift your hands and again rotate. And every 2 minutes during the procedure, auscultate the FHR and it should be reassured. And you can try it for maximum 4 attempts in the period of 10 minutes. This is your GTG guideline, where they tell 4 attempts in 10 minutes. If it fails, it's failed. You can repeat after 1 week. I will repeat what I was telling. Firstly, the mother should avoid and lie down in dorsal position. The clinician should stand on the right side of the patient. Under ultrasound guidance, the presentation is confirmed. The podalic pole is grasped with one hand. The cephalic pole is grasped with other hand. Decide whether you want to do a forward roll or a backward flip and slightly move the baby. And prior to ECV, do a 20-minute strip of NST, which has to be reassuring. And check the placenta. Anterior placenta is slightly difficult to perform when compared to posterior placenta. And then you will slightly move the baby. And once you reach the transverse, you will shift your hands and again move. And every 2 minutes during the procedure, we have to auscultate the FHR to see if it is reassuring. And after the ECV, again do an ultrasound to confirm that your ECV is successful. You can maximum try for 4 attempts in a period of 10 minutes. And if it goes beyond, stop the procedure and try after 1 week. And after ECV also, do a strip of NST for 20 minutes to see the FHR is reassuring. Uterus should be relaxed. There should not be any leaking PV, bleeding PV or pain abdomen by the end of procedure. So that you have ruled out true labor pain, abruption or PROM. And fetal heart status should be checked even after at the end of the procedure. So pre and post, do a strip of 20 minutes NST to see that the heart rate is reassuring. So this is about the procedure of ECV. So the forward roll or a backward flip, somersault or a reverse somersault. The success rate of ECV is around 65 to 70%. Failure rate in a nulliparous woman, it is 2%. In a multiparous woman, it is around 13%. So an average failure rate about 10%. Nulliparous, it is more successful. Because once if you turn, the chances of reversion is less. Whereas in a multiparous woman, the chances of reversion is slightly higher.
Can you repeat that, ma'am?
The success rate is around 65 to 70%. The failure rate in a nulliparous is 2%. In a multiparous, it is 13%. And an average failure rate is around 10%. Nulliparous, because of the taut abdominal wall, the spontaneous reversion rate is slightly less when compared to a multiparous woman. And once ECV is failed, you can attempt once more after 1 week. Again, if it is failed, then you have to take her up for a cesarean section. Okay, not more than 2 attempts of ECV in an interval of 1 week should be done. Okay, and ideally it should be performed between 36 to 37 weeks of gestation. And the alternatives for ECV is something called as moxibustion. You've heard moxibustion. It is some Chinese method, it seems. They have some herb called Artemisia vulgaris. So they will light that herb and they will keep that heat to the little toe of the mother. So it will have some uterine activity and it will turn the baby into cephalic. That is some Chinese theory, which is given in all books. It's given in Williams also. It is given in GTG also. So in GTG, they have recommended do moxibustion from 33 to 35 weeks. If it fails, do ECV. So I had to mention because the evidence also says that moxibustion has some reversion. Okay. Some yoga teachers tell doing some yogas also cause to become cephalic. I have really no idea. If you have any person who teaches
HOD.
prenatal,
My HOD would be
okay,
so happy. He loves all these
yeah,
non-modern medicine things.
yeah, I don't know. I'm not. I practice only allopathy. I don't know Ayurveda, Ayush, and all. So if you have people who have little idea about prenatal yoga, they tell prenatal yoga also has slight chances of reversion to cephalic, but I really have no idea, and it is not mentioned in any textbooks or guidelines. But yeah, so that is also there prenatal yoga, but we don't know what yoga, what exercise to be done. I don't know. But under ECV, you have to follow all these headings. So any doubt? My Yashaswini, did you understand?
Ah, yes, ma'am.